thank you all for coming. I know this is sort of the dregs of the conference here at the end, and lots of people are trying to run to the airport, so we very much appreciate you coming here and listening to our talk and supporting us. We'll start by just kind of introducing ourselves and then give a little bit of an outline of how we think today is going to run. But I just want to preemptively warn you, we would love for this to be interactive. So in a couple slides, there's going to be a QR code that will take you to a living document that we all have access to. So if you have comments, questions, things that you would like the panel to address, please feel free to add those at any time. So the title of our talk today is Don't Drown, How to Transition Swimmingly from Resident to Faculty in Academic Emergency Medicine. I'm going to go ahead and let the panel just introduce themselves. They decided not to sit in order, so I apologize for that. But we're going to go down the order that they're listed on the slide. So first of all, Dr. Lee Sauerwein.
Okay. Hi, everyone. My name is Danielle Lee Sauerwein. I am an assistant professor and assistant program director at Ohio State University in the emergency medicine program. I'm 10 months out of residency, and in terms of other things that I do, I direct the Resident Wellness Endowment at Ohio State, and I also am the Chief Academic Officer of the Alien Wellness Think Tank.
Dr. Klein.
So my name is Matt Klein. I am the current Med Ed Fellow at Northwestern, where I'm also serving as Interim Assistant Program Director during my fellowship, interested in undergraduate medical education and simulation, and excited to be here.
Dr. Ketterer.
I'm Andrew Ketterer. I am now almost 2 years out of residency. I'm an instructor and Assistant Program Director at Beth Israel Deaconess Medical Center in Boston.
Dr. Wyant.
And I'm Logan Wyant. I'm an assistant professor and assistant program director at Johns Hopkins, and I do some work in low-frequency, high-risk procedural training.
And I'm your moderator today. I'm Abra Fant. I am also an APD at Northwestern. Do a lot of work in safety quality education as well, and I am finishing my 4th year out, which is making me almost not a junior faculty anymore, which is sad for me. All right, so today what we're going to try to cover is some common aphorisms of advice for new attendings. So for those of you that are senior residents or new out, or even those kind of looking back to the days when you were first out, you probably got a lot of advice, and a lot of it probably overlapped. So we're going to go through some of those common things and sort of our strategies and thoughts around them. Secondly, we will identify strategies to how to interpret that advice and really how to be very successful in making this transition. So as I mentioned, this is our QR code, so please feel free to go ahead and pull up that Google Doc. I will be checking it here as well so we can forward the questions or comments you have to the panel. So please feel free to add into that at any point in time. So our combined experience has really taught us that most of the advice that is given to graduating residents, early attendings, really can fall into 3 categories. So that's how we're going to structure the talk today. We are all in academics, so we are going to start with kind of the academic advice, then move to the clinical, and then just the general category of life advice towards the end. So, beginning with academics. Academic aphorism number 1, you work for your chair. So I believe that Dr. Wyant is going to take this one first.
So this was something I didn't necessarily realize until I started the application process and going on interviews. I found that it is very important to understand what the chair is hoping and what direction they want to take their department in over the next several years to find out if you actually fit with that chair's goals and ideas. I went to one institution, I interviewed there, and I clearly was not what that chair wanted, and it made for a very awkward interview that wasn't terribly fruitful. And then after arriving, finding out what your chair values at your institution. Maybe your chair values research or values participation in conference or even the social events. Finding out what your chair really wants you to focus on and be present at can really help you establish yourself well in a new department.
Yeah. As a sort of object lesson with that sort of thing too, actually Logan and I had tried to get a research project off the ground that had to do with basically implementing low-frequency, high-risk procedures like cricothyrotomies and so on into teaching on shift. But the problem is that by doing that, you're impacting some of the other metrics that our chair at the time value, including patient throughput and so on. And when your chair is when your chair's interests are not aligned with the project that you want to do, the kibosh can be put on that project very quickly, as we learn. So that's something I think that's important to carry forward. But I mean, it's helpful in both residency, but definitely important to carry forward in junior or professional life as well.
Would someone like to kind of talk a little bit about how to negotiate that relationship where you work for your chair, but you may also have a director above you that you're reporting to?
I think it's really important to consider yourself part of a team. So I have two of my team members here in the front row today. And really you have to make sure that you as a team have a combined vision. So as our educational leadership for the residents, you want to make sure that you're all on the same page, and then you can present a united front to your chair in terms of the things that you're hoping to advocate for. So that's super important. I think the other thing too, in terms of trying to identify the goals of your chair, is it's okay when you first show up to say, hey, you know what, like I'm new at this, it would be nice to have your mentorship, and you can set up, maybe meetings every quarter with your chair to just check in and say, here's how things are going, here's where I might need a little bit of extra help, what are your thoughts on X, Y, or Z?
Dr. Klein, any thoughts from working in the interesting space of being a fellow yet still working for your chair?
Yeah, I think some of the best advice I've gotten from my fellowship director, similar to the themes we've talked about, is kind of making sure that the alignment of the institutional goals with your research goals. And so we've talked about different projects, but knowing that our shop, there's a big emphasis on simulation-based mastery learning. And so trying to integrate that into the context of my fellowship, you'll find that there's a lot more engagement with the other folks that you need, not necessarily just in your department, but around and across the institution to provide different pockets of funding and things like that. So keeping that alignment is very important.
So the key on this one is alignment. Ultimately, the chair is the person at whom you are being employed, so their discretion is you are employed at their discretion, we'll put it that way. But there are lots of other folks that work in the emergency department that will work on your team. So making sure that everybody is transparent about their goals and that you are also transparent about the goals that you want to have as you pursue your career.
Dr. Fant, we may want to put the QR code back up for a minute. I don't think everybody had a chance to swipe into that. So for those of you who may have walked in just a minute ago, this QR code is to a living Google document, and we would love to see your questions, suggestions, thoughts in real time. We're monitoring them, and so we'll keep a few notes on there, and please contribute as you'd like.
And for those of you who are latecomers to technology like me, you can actually access this QR code just through the camera on your iPhone. You don't need a separate app or anything. So this blew my mind like a month ago.
Simeo is a very bad millennial.
We'll also take faxes.
And if you don't know what a QR code is, you can also just enter that little URL or that line of text into your browser, and it will get you there.
Everybody good on the QR code? Awesome. All right, so we're going to move on to aphorism 2, find a sponsor or a mentor, and network, network, network. Dr. Ketterer, this one goes to you.
So this is probably the most palpable difference between residency and being a junior attending, right? Because all of us in our professional and academic development have had very almost rigidly structured mentorship networks, right? You're in medical school and you've got your deans and your professors and everybody and all these people like guiding your development, and there's formal setups for who you're going to talk to under what circumstances. Similar sort of construction when you're in residency, where you've got your PD and your APDs, and usually an assigned faculty mentor or a faculty mentor that develops based on your own choice. But that stops existing once you are junior faculty to anywhere nearly as rigid of a degree. And so it's sort of like, okay, you're being told what to do under specific circumstances throughout your career, and now figure it out yourself, which can be pretty disorienting, especially if you're starting up a junior faculty job at a new shop. And I think there's a couple of different ways that you can combat this. So first of all of your previous faculty mentors still exist. It's not like their email stops working the moment you graduate. So even if you happen to be moving across the country, you can still do research with them. You can still ask them for advice. Kind of a personal note in that regard, when I finished my medical education fellowship, I had to go out on faculty search again, and I leaned on my chair during residency, my former program director during residency, and many of the other people who had helped guide my development during residency as well for advice in that particular regard, just because I had relationships with them that I didn't have at the shop that I was at in my fellowship, because I'd only been there for a couple of months because it was a one-year fellowship. So that's important to keep in mind, and important to know that these people still care about you and are still contactable once you graduate residency. A second kind of point of advice is to use those connections that previously exist to sort of get in with people maybe at your new shop, maybe people at places where you want to work, because this is academic emergency medicine is a small world. All of us here have seen people from all across the country who we probably recognize from previous meetings or previous other walks of life. And using those connections to maybe bridge you into, oh, here's a person who is doing something that you're interested in, maybe you guys should talk to each other, is extremely helpful. So you can take that first set of people that you already worked with and use them to bridge to a new set of people. The other thing that I didn't appreciate as much during residency, which I think is pretty crucial to what I do now, is peer mentorship networks. So among these fine people that you see in front of you, we all work together and are working on various research projects together. Obviously, we do things like SAEM talks together, and having peer mentorship networks not only to help you create new ideas for what you want to do going forward, but also to give you feedback on projects that maybe they're not immediately involved in, but are interested in your own success, and then it becomes a sort of feedback cycle with one another. So those three general strategies: utilize your old mentorship networks, use them to build new mentorship networks, and use your peers to help form mutual mentorship along, I think are extremely helpful to navigate the kind of free-form version of academia that kind of pounces itself on you when you're a junior faculty member that is so different from what you previously had done.
Yeah. And you guys, oh, sorry, go ahead.
I will also add that there are many formal networks that you can plug into nationally for whatever you're interested in. So for our medical education nerds, that would be things like the Market Cord program, like the ALIUM Faculty Incubator. I've benefited hugely from those, and you can actually take part in the national conversation and meet all these people outside of your institution that you then get to work on projects with and bounce ideas off of. So rather than, like, in addition to leaning on your personal relationships, there's also these structured means to get that means of making a connection as well.
I would just also add that you can make these connections outside of the broader field of emergency medicine. I think that's been a nice part of the experience for me in fellowship, though I'm staying at the same institution. I'm starting to branch out into other departments, particularly in like our Office of Medical Education and the Dean's Office, and making those connections. There's a lot of great potential and resource there that isn't always available to you during the course of residency, and that's become a real source of value over the past 10 months for me.
And just to echo that, the interdepartmental collaboration can be very useful when going up for promotion. Chairs and promotion committees often look very favorably if you get dual appointment or doing a lot of collaborative work across departments.
And you guys are all lucky. You are in a fantastically friendly specialty. So when all else fails, cold emails, walking up to people at meetings like this, everyone is actually more than willing to utilize their experience and expertise to help you get to where you want to go as well. So lots and lots of different ways to reach out, even when it's not quite as structured as what you were used to in residency, to make sure that you continue to have that mentorship and sponsorship. All right. Our final academic aphorism, everyone's favorite: find your niche.
So I'll start off on this one. And, you hear this all the time, but what does it actually mean, right? So I think in residency already, you are likely to have identified maybe a couple areas of interest, and that's what's led you down certain academic projects. I would say make sure that you sort of think about those in your mind as discrete topics that you may want to delve further into at your new shop. The other part of this, though, is to actually be open to new opportunities. So specifically for me, it meant when I came to my new shop, there was a need for someone to lead up the resident wellness endowment. And so I was able to sort of take charge of this thing that I didn't know whether or not I had an area of expertise or didn't have a previous sort of like proven track record in it. But now it's actually become one of the biggest sort of interest areas for me. And so keeping an eye out for those new opportunities, and especially if there are things that, are currently important in the national conversation.
And to kind of circle back to our first one, if you don't necessarily have a niche yet, think about what the needs of your department and your chair are and use that to explore some opportunities. Also know that niches are not permanent. It's okay to change your career trajectory and your goals if things aren't working out or you've decided this is no longer what you want to pursue. So this is not a lifelong commitment. You're not marrying this niche, but it is a really nice way to distinguish yourself sort of in the job hunt and when you're first out in academia, that you are the person who knows about X.
And to connect it to our second aphorism, chances are, if you are also undifferentiated, chances are there's something that irritates you that you encounter on shift or in academia or something, and chances are good that that same thing bugs other people, and finding out who also is annoyed by the things that you're annoyed about will foster relationships so that you can work on similar projects and form mutual mentorship relationships as well.
An alliance of annoyances.
Alliances of annoyances.
One other thing is save anything you do, because even if you do a quick presentation at a conference like your Wednesday or Friday conference, that may eventually become a niche for you. And you don't want to have to reinvent the wheel every time you do something. The program director asked us to have a talk on implicit bias, and now we've rolled that talk into both local and national stage presentations, and it's become a niche just because, like, essentially our program director was like, hey, can you talk on this thing? So it's very easy to develop new or multiple niches that way.
Awesome. Does anybody have anything? I don't see any questions on the Google Doc yet, but if anybody just wants to shout something out about academic aphorisms, pursuing an academic career early on, otherwise we'll move on to clinical. It's okay. It's totally fine. The document is there, so again, feel free to utilize it. Oh, yes.
Quick question.
Perfect.
I'm going to be taking a job where I have some split FTE. I'm going to have multiple bosses, which I presume is going to be both a huge advantage and a huge disadvantage. Does anyone have any expertise in dealing with that? Not being overcommitted?
Multiple bosses, like over multiple departments or within the same department? Different departments. So that's, I think, that's something that a lot of people who do like critical care and EM, for example, tend to find challenging, because essentially you're trying to make people with very different interests happy at the same time. Not doing that myself, I don't have any personal experience in that regard, but I think probably developing initiatives that benefit both. So to take the critical care example, you know, creating a DKA pathway so that you maybe save critical care beds by acting early in the emergency department and appropriately streamlining care is one way to make both your EM boss happy and your internal medicine critical care boss happy, for example, just to pull something straight out of the air.
Yeah. So to kind of specifically answer your question about managing time, so I have 3 bosses that own different percentages of my 100% time. And it's very difficult. So I'm sure most of you guys know that whenever we say 100% effort, we're usually doing much more than that, right? Anything that we do is not a 40-hour week. We're putting in extra hours. So with that caveat aside, I think you do have to be very transparent with all of your bosses to say, my pie is 100%, you get 15 of this, and that means this many hours a week. And I just can't commit to more than that, because that's what I'm getting paid to do. And if you set those rules up front so that they know that they can't continue to chip away at other people's portions of the pie, I think that's very, very important. So for me, that actually involves having them also talk to each other and having things in writing. So making sure that when you have these agreements and they're saying you're getting a 15% buy down, that that's in writing, and that you show that to your other boss that says, okay, this 15% of my time is bought by these other people. I can't give you any of that 15%. It's not an easy conversation to have, but if you start early with it and you make sure everything is out in the open, it avoids any trouble later where all of a sudden you've got both bosses asking for more from you and there's only 100% of you to give. Awesome. All right, so I know not everybody is 100% invested in academia, so our next little section is really going to be much more the advice that comes from being a brand new clinical attending and a lot of the challenges that come up with that. So our first clinical aphorism is, do what helps you sleep at night. Dr. Klein, this one goes to you.
Yeah, so I think that this is commonly interpreted as erring on the side of being conservative in your first couple months out, which is completely appropriate. I think early in your career, it's not the time to be playing fast and loose. It's not the time to be overly concerned with metrics in your department. And when you are faced with that kind of soft call, erring on the side of admitting or getting the imaging study certainly makes sense. I think in my experience, I've been surprised in these 10 months how often doing what helps me sleep at night is the opposite of that, and particularly canceling imaging studies or de-escalating workups. I think some of it's the benefit of being the attending and having a little bit more time in the room when you're not tasked with calling all the consults and doing the bulk of the documentation, that you have a little bit more time at the bedside to have those shared decision-making conversations with people and talk about the risks, benefits, and saving them the cost or the exposure to the radiation. But finding what feels appropriate to you and kind of figuring out what that is, allowing for the fact that it's a kind of a case-by-case basis, is important to promote your own wellness, but making sure that you're not feeling that you're putting your young career in jeopardy as you're kind of starting things off.
I would add to that too is that right now I think it's easy as a resident to practice in the way that you know that the attending you're closely working with prefers to make decisions. And over the course of your 3 or 4 years, you really get to know which attendings like to do what. But one of the best pieces of advice that I had gotten as a resident was figure out why you're doing what you're doing right now. Whether it's because you're trying to establish your practice pattern or because there's specific data to back it up. So on your first day as an attending, you feel 100% comfortable making that same decision.
I think also you get used to the idea of seeing report cards as you sort of go through your clinical and non-clinical training, and a lot of institutions will give you a report card day one. I would suggest that you try to stay somewhere on the average to slower than average and more conservative than average initially. You may not be seeing 3 or 4 patients an hour the first 2 weeks you're in attending, and that's okay. From what I understand, a lot of the clinical directors give you a couple of years to sort of get up to speed and establish your practice pattern. So you don't necessarily have to be sprinting out of the gate, and safely warming up is probably a better idea.
I think the other important thing is to ask around and know what the practice patterns are where you go. It's very easy to fall into practice patterns when you're in training that are what your faculty do, and that may or may not be what the practice is when you go to another shop. So making sure that you are not the super, super conservative or the crazy cowboy from day one. And so kind of asking people, what is the typical management for low-risk chest pain here? Are we definitely a heart score place where they get one trope and they're out? Or is this a little bit more conservative? I'm not saying that you have to stay in that practice pattern for too long, but when you first get started, I think it's very reasonable to kind of be within the center part of the bell curve for the other people with whom you're practicing.
It's especially true if you're at a new shop too. If you're staying, where you trained for residency, you're already familiar with the culture and the way people do things, but it's just going to take you time to get used to the vibe at your new place if you're working at a new place.
All right, clinical aphorism 2, learn everyone's name. Dr. Wyatt.
So this is a fairly simple concept, but it's amazingly valuable. And learning names of people beyond just the other attendings you're working with, but the residents, the nurses, the EDAs, the support staff, the more you get to know people and learn their names, the more you engender mutual respect and you create a team around yourself. And it can be a very effective tool in integrating into a new department where you may not know anyone. The other thing is they won't get mad if you ask their name multiple times early, but if you wait a year or two, then they tend to not appreciate it quite so much.
It's real awkward.
I would expand on that and also say, you don't need to have a 20-minute conversation with your nurse or EDA or even your custodian, but it is nice if something comes up to say, hey, you know what, I heard that your kid was having a hard time. how are they doing now a few weeks later? That means a lot to people, and I think it's a basis for building personal relationships so that you're not just some attending who shows up for 12 or 15 shifts a month, that you're actually someone that they enjoy seeing when you show up to your shift.
I think it also goes a long way to kind of establishing your confidence in your department, right? And it's easier for me as somebody who's staying at the same shop where I trained, but I think it was my second shift where I had a critically ill patient with multiple consultants kind of in the room in kind of a high-stakes situation, and the fact that I could kind of point to individual people by name and kind of request specific things kind of showed that this was my home turf, this was my base, and I was ultimately the attending of record kind of managing this resuscitation. And so that helps you project that image that you want as a clinically competent attending.
And food goes a long way. My residents know I bring candy to shift a lot, and that is not just for the residents, that is for the entire team. We work in a hard environment. Every single one of you has really tough shifts. You have boarding and horrible wait times and all those things, and everyone feels that it's not just the physicians. So showing that you care, bringing a little bit of something in for people to kind of just take a quick break, get a little sugar, get a little fruit, whatever it is, it really, really helps. So that's my little pearl for new attendings. Feed your staff.
And I think along the same vein, remembering that you're sort of the captain of the ship and you're in charge of keeping your space safe is really important. I received the advice to throw somebody out in your first month. I don't know if I would necessarily take it quite that far, but knowing when you need to bring in security or verbally or chemically de-escalate a situation is important. And you'll find that, especially if you're establishing yourself in a new shop, if you are dedicated to keeping your staff safe, it will really make you a lot of friends and win you a lot of support.
All right. Clinical aphorism 3. Trust, but verify. This one's Ketter, I believe.
Absolutely, yeah. So, I mean, everybody's heard this at some point. Whenever they become a senior resident, someone has probably thrown the advice at you is, yeah, listen to what your junior residents say, but, when they tell you the x-ray is normal, look at the read. And that's absolutely true as an attending as well. Again, especially if you're going to a new shop compared to your old one where you don't necessarily know everybody, you don't necessarily know how thorough everyone is. So it's just a good system to get in the habit of being a part of, is to, make sure that you look at everything that everybody has done, at least in a glancing fashion. The same goes doubly true for consultants, especially in unfamiliar situations, or maybe someone you don't talk to that often. I think it's something that definitely was useful for me as a senior resident, and absolutely has been something that I've had to carry forward as a junior attendant in particular. And that also goes for your colleagues in the emergency department too, right? So when you're receiving sign-out on patients and there's still things pending on patients who are signed out to you, just go and look through things, because A, there might have been something that got missed. B, there will be an increased sense of comfort around continuing that care, pushing that patient's care forward, if you're familiar with the details of what the CAT scan showed yourself, for example.
I think from the perspective of somebody who's staying where I trained, that trust but verify is in the context of working with people who were your co-residents just a few months ago and your friends and colleagues. And so I think it requires a little bit of nuance as you're navigating that relationship now as a new attending. And so I find that the context in which you do the verification can be really important. Looking at it from an educational perspective and saying, hey, just, this is my understanding of how this works. And I think some of the best advice that I got is, particularly when you're changing plans of the residents with whom you're working, making sure to take that extra minute to explain your thought process, right? And understanding that your residents, who are not necessarily much, younger than you are, and you have relatively similar clinical experience, have very deliberate reasons for why they're doing the work that they're doing, and allowing for practice variations, but explaining what your underlying rationale is. And I think that can kind of help smooth out what can sometimes be occasionally a fraught situation.
Yeah.
And some of this actually can be for yourself as well. It's important to trust your gut and to trust your instincts, but early on, it's okay to also have the desire to verify that. So if you're working at a place that's not single coverage, it's totally fine to walk over and ask the other attending, hey, what do you think about this? Or, does this make sense to you? I mean, we do it even now. I had a case with Emily Powell, who's sitting here in the audience, where, we had this really weird finger, and she had me come look at it, and we sat and we put our heads together and thought, man, I don't know, this looks like a really weird finger infection. But having the confidence that it's okay to ask for help, I think is very, very important. And for those of you that are going to be going to single coverage shops, this comes back to your network. All of the folks that trained you are still on the other side of the telephone. So you know the phone number in the ED that you trained. You probably still have access to their scheduling so that you can look and see who's on. It's totally fine. Pick up the phone, call, and run stuff by them as well. So trust yourself, trust your gut. You're going to be making the right decisions, but also be totally comfortable with asking for that help and that verification. All right, any other questions from the clinical side of things? All right, on to our final category, just general life aphorisms for just being an emergency physician. So the first one we're going to talk about is establishing your brand. You've probably heard a lot of this at conferences like this. So Dr. Sauerwein.
So I think this was one of the best pieces of advice that I had received when I was graduating residency, is that I had one of the faculty members at my old shop say, you know what, make sure that you establish your brand as someone who shows up, is positive, and get things done. So if you're able to prove that in the first few months that you're at a new place, then people will know that you're someone that they want to work with, that they trust, and that you'll actually be bringing deliverables. I think it's a lot harder if you drop the ball earlier on to have people want to continue to collaborate with you. It is really difficult to balance the clinical demands and administrative demands when you first show up to your new job. But it is important to prioritize the things that are visible so that people understand that you're someone they want to work with.
Yeah, to that end, I think you have a sense of how you want to be recognized by your peers, be them residents or co-faculty, and there's a lot in that relationship that you don't have control over, but you can certainly manage the outputs, right? And so being deliberate about what you want to signal to people. And so my residents in the room know that I'm the dork who will send out a lot of post-shift emails with evidence-based papers and things like that, and that is something that I decided that was important for me and kind of how I wanted to be known as somebody who's going to take that time to provide that type of education. I can't control how well those are received or how quickly those emails get deleted, but I can know that this is something that is kind of my shtick, and it allows you to kind of help develop that brand. If you want to be that educator, then that's something that's within your power to control.
And this is another one of those situations where you can absolutely steal like an artist. So a lot of the things I do on shift, the feedback, I have a script from somebody that was one of my mentors before that I thought was fantastic, and I use it, and everybody's like, wow, you're the feedback guy. I'm like, yep. So you can kind of roll your favorite attendings into one and become that person. It's a chance to redefine yourself. I think it's also very important early on to be a strong patient advocate without fighting. If you are coming into a new shop and start fighting with consultants, it doesn't establish a good relationship with your consultants, and you really have only one chance to make that first impression. That doesn't mean that you need to necessarily, sort of hand off to them and let them do whatever they want, but being a strong advocate without fighting is important.
Yeah, I would just say as a corollary to that, some of the best advice I got from one of my faculty was not fighting systems level issues at the patient level, and really trying to be mindful of that when you're working in the middle of a busy shift.
I think the other part of this too is understanding what the culture of your department is in terms of the departmental brand as well. So at some clinical shops, everyone wears scrubs. At some clinical shops, the expectation is that if you're on a day shift, you're going to be in a suit and tie or in some sort of whatever business casual or dress clothing. And so it is important to be attuned to that and to have that be a visual signal that yes, you are on board and that you're presenting a united front with respect to patient care.
And that goes for non-clinical aspects too, right? So if you're going to faculty meeting, for example, still dress for the job that you want, because if you come in a hoodie and like dirty scrubs, your chair is going to see you like that, and that first impression is really hard to slough off once you've made it. So being aware of the appearance that you're projecting even when you're not on shift is incredibly important.
All right. My second favorite aphorism next to find your niche, say yes. Dr. Klein.
So we hear this all the time, right? This is a really common maxim that we're given, and particularly as new faculty, this is absolutely encouraged, right? You want to be seen as the proactive person, the person who's aligning with the interests of the chair. I would add to this saying yes with expectations or with qualifications. It's something that I've been navigating, particularly the past few weeks, is things have become really, a lot of different projects that I'm involved in have kind of come to fruition at the same time, which has created some more competing demands on my time. And so saying yes to doing the data cleaning for a project that we're working on, with the caveat that I'm going to be able to get to it after I've finished oral boards and returned from SAEM and done final reviews of another paper that we're resubmitting, right? And so allowing people that context as opposed to just saying yes, and then when you don't meet their time frame or they aren't understanding what you're saying yes to in context with, and then assume that you're dropping a ball, right? And so I think that can be really helpful for you, so you're not feeling that stress of under-delivering and signaling to the folks that you're working with that you're committed, but here's the context in which that I'm going to deliver on.
And for things that are not discrete projects, making sure that you're saying yes with an end point. So as junior faculty, you're going to be asked to join a lot of committees. And that's a good thing. It gives you exposure. It helps with the networking and all the things we talked about, kind of the interdisciplinary aspects of networking. But it's also important to do that with an endpoint. This is not, I am in perpetuity going to serve on this committee. It's, I'm happy to try this for a year. I appreciate the opportunity. I'm so glad that you're looking out for my professional development. I'm happy to do this for a year. At the end of that year, we'll reassess if this is still totally in line with my goals. Great. Otherwise, I'm happy to look at other opportunities at that point.
This sort of gets into the old kind of Oracle of Delphi kind of know yourself sort of advice that is present in basically every self-help book. But it really does come down to, know what you're interested in, know how much time you have, know how much bandwidth you have, whether it's because you're overstretched academically or because you've got family obligations or whatever. Be aware of the various competing aspects on your time and what makes you happy, and take everything that you say yes to in the context of all of those other considerations.
All right. Our last one, the most important, love your job.
So this is hard, right? Like, we all have hard, stressful jobs, and none of it's ever going to be perfect. I mean, when we were all applying for residency, we're all concerned, did I go into the right specialty? Am I going to find the perfect shop for where I can train? Does everybody, do all the faculty, their interests align with the specific things that I have in mind? And it's never going to be perfect. You're always going to have gripes, and maybe you'll join a new job after you graduate residency, and you'll be over the moon for it, have this long honeymoon period, and then all of a sudden something happens, and it kind of caves in on you, and you're like, wait, what have I gotten myself into? Maybe you get into a new job and you don't have that honeymoon period and you're unhappy about it at first. Understanding why you feel that way is going to be the biggest thing to changing things if they need to be done. And a lot of times that just takes a tincture of time, right? So if you're unhappy for a period of time, maybe it's just because there's a variety of things that are overwhelming you at the moment and that will get better. Or maybe there's a problem at a systems level that's being worked on by people at a higher level than what you can maybe see in the trenches on shift. Giving it some time, and if you're still unhappy after a period of time, doing a sort of self-root cause analysis for why you're unhappy and not being afraid to change things up to fix that. Because ultimately all of this is about finding a way to have a fulfilling career and fulfilling kind of trajectory in academic medicine. And figuring out what it is to take that is one of, I think, the big questions that we all kind of struggle with, especially kind of at the early levels when we're just trying to figure out which direction our professional lives are going to take.
I think what I would add to that, and what I found over the past 10, 11 months, is avoiding unforced errors that force you to love your job less. And so as a new fellow faculty member, I have much more control over my schedule than I did as a resident. And I wish I could say I've always used that appropriately, but having found myself in a couple scenarios where I've done an 8-hour day of teaching in a sim lab and then, due to not having enough foresight, then followed that up immediately with an 8-hour shift for a 16-hour day and then a quick turnaround into another day of meetings, that impacts my ability to love my job. And so having a little bit more of that forethought and controlling what you can control. There are obviously things that you can't, but as much as it's in your power to be deliberate about your schedule, that can really impact your wellness.
And to kind of build off of what Keter was saying in terms of changing, if you've done your sort of root cause analysis about your own unhappiness, changing doesn't necessarily mean leaving your institution and getting another job somewhere else. Sometimes it might, and sometimes it's leaving a geographic area and going somewhere else. You know, you may have thought that you could handle Chicago winters, but you're a Southern kid at heart and you really need to get back to the sunshine, and that's okay. But it's also finding new directions at your own institution. So it's important to constantly reevaluate if you are feeling fulfilled in what you're doing in both the clinical and non-clinical arenas. And if that's not the case, it doesn't necessarily mean you have to burn all your bridges and start somewhere else. It may just mean finding a different direction in that same institution. So just be aware that change doesn't have to be totally drastic, moving across the country to an entirely different place. All right. Well, those are our thoughts, our deep thoughts on this Friday afternoon. What questions do you guys have for us? We have a few minutes left. Excellent. Well, thank you again so much for sticking it out to the end with us here. We really appreciate it. I believe all of our contact information should be on the app, so if anything comes up later, please feel free. You also still all have the link for this Google Doc, so you can shoot us questions through that as well. Just make sure you tag it with an email so we can respond to you. Thank you guys so much.